Anesthesia. Infiltration techniques. The current options for anesthesia are dry, wet, super wet, and tumescent. The essential differences between these techniques focus on the amount of infiltrating solution injected into the tissues and the resultant blood loss as a percentage of aspirated fluid. The dry technique. Fournier described the dry technique of liposuction in 1983. In dry technique, no infused fluid, however, due to the significant volume of blood loss in the lipoaspirate reaching 20 to 40%, the technique has fallen out of favor. The wet technique. ILAs introduced this technique, and it included infiltrating 200 to 300 cubic centimeters of infusate fluid regardless of the volume to be aspirated. The blood loss in the lipoaspirate was reduced to 8 to 10%. The wet technique evolved by introducing the addition of epinephrine, further reducing the blood loss in the infranatant of the lipoaspirate as a result of the vasoconstriction of vessels. This blood loss was 4 to 8%. The super wet technique. The super wet technique meant injecting 1 cc of infusion to 1.5 cubic centimeters of lipoaspirate. Fodor 1986 described this technique. The technique meant the blood loss in the lipoaspirate was reduced to less than 1%. The tumescent technique. Klein, a dermatologist, introduced the tumescent technique, which was popularized in 1990s. The tumescent infiltration technique uses the skin turgor and its color changed to white as end points on the volume injected. The infusate to lipoaspirate is usually 2-3:1. It uses a mixture of 50 cubic centimeters of 1% lidocaine infiltrated in 1 liter of normal saline, 1 cubic centimeter of 1 to 1000 adrenaline with 10 cubic centimeters of 8.4% sodium bicarbonate solution. The latter helps reduce the pain at infiltration. The pH of normal saline is 5, adding bicarbonate makes it less acidic and leaves less ionized lidocaine outside the cell for absorption. This means large volume of dilute lidocaine with concentration of up to 35 mg per kilogram can be injected into the fat. This is much higher than the toxic doses when injecting undiluted lidocaine mixture at 7 mg per kilogram. An added advantage of the tumescent infiltration is decreased need for intravenous fluid replacement. Regardless of technique, the infiltrate should be allowed to take effect for 7 minutes prior to suctioning. Areas to be treated should not be infiltrated more than 30 minutes in advance to allow full effect of solutions. When infusing large volumes and aspirating large volumes, for example 3 liters or more, one must replace for each ml of aspirated fat up to 2 ml of fluid in the first 24 hours. For example, in a case of 3 liters injected for 3 liters aspirated, it is estimated that around 20% of the injected fluid will be removed with the lipoaspirate. This will leave 2.4 liters in the extracellular space, warranting a total fluid volume replacement of 3.6 liters in the first 24 hours. It is important to stress that in such large volume lipoaspiration, urine output should be monitored for the first 24 hours, adding safety to the patient management. Practical tips. In large volume cases with aspirate greater than 5,000 milliliters, the initial 5 bags of solution are mixed in a standard Southwestern protocol: Ringer's lactate, 1,000 milliliters plus 1% lidocaine, 30 milliliters plus 1:1000 epinephrine, 1 milliliter. After 5 L of infiltration, the remaining bags of infiltrate contain lidocaine 1% plain, at a volume of 15 milliliters per liter. Lidocaine toxicity has central nervous system and cardiac effects, with the first signs of toxicity being circumoral numbness, tinnitus, and lightheadedness. Intraoperative manifestations may include arrhythmias. Increasing levels cause tremors, seizures, and eventually cardiac and respiratory arrest. Klein's tumescent technique has been gradually embraced by all medical specialties because of its advantages, including especially bleeding reduction. With awake tumescent liposuction, the patient is able to drink normally the night before and the day of surgery, eliminating the need to replace deficits after important bleeding, avoiding the risks of postoperative overhydration or underhydration. Medications in wetting solutions. Lidocaine. A safe maximum dosage for tumescent lidocaine was shown to be 35 mg per kilogram by Klein, although it is generally accepted that lidocaine doses up to 50 mg per kilogram and even 55 mg per kilogram are safe to use in tumescent liposuction. The American Society of Plastic Surgeons guidelines recommends 35 mg per kilogram as the maximum dose. Epinephrine. Epinephrine causes vasoconstriction, resulting in hemostasis and delayed absorption of the anesthetic agent. It is recommended that the maximum safe dose of epinephrine is considered to be 0.7 mg per kilogram, although doses as high as 10 mg already have been used safely. Sodium bicarbonate. When lidocaine is used for local, subcutaneous injections, patients often complain of pain thought to be related to the pH, 3.5 to 7.0, of most commercial lidocaine solutions. Some data suggest that alkalization of lidocaine does in fact reduce the level of pain associated with its injection. My favorite tumescent fluid. The tumescent infiltration fluid is made using lactated Ringer's solution 1000 ml. Plain lidocaine 1% 25 ml. Epinephrine 1:1000/ml. Lactated Ringer's is superior to normal saline for tumescent infiltration for many reasons. The pH is relatively neutral at 6.5, whereas normal saline is quite acidic at pH 5.0. Because of this neutral pH, it is not necessary to add sodium bicarbonate to lactated Ringer's-based tumescent fluid, as it is with normal saline-based fluid. Ringer's lactate is more physiologic than saline and is very useful for fat grafting. There is 3.5 milliequivalent/L less sodium in lactated Ringer's than in normal saline. Liposuction volume. Large volume liposuction is defined as the removal of 5,000 cubic centimeters or greater of total aspirate during a single procedure. A review of the literature shows that there are no scientific data available to support a specific volume maximum at which point liposuction is no longer safe. Body mass index and the potential physiological consequences of the tissue loss should be considered to ensure that the volume of aspirate removed is proportional to the patient's overall size and medical condition. It is important to note the distinction between total fat removed and total aspirate removed. Total aspirate is defined as the combination of total fat and fluid that is removed during liposuction. It is the position of the ASPS that when referring to liposuction volume, total aspirate should be the volume recorded. Megaliposuction, a procedure in which an amount greater than 10% of body weight is removed, can be safely performed by an experienced surgeon. Large volume liposuction procedures should be performed under general anesthesia. Harvested fat may be used for subsequent fat transfer. Treatment modalities. Once candidates are identified for liposuction, several modalities exist for treatment depending on the following factors. Surgeon preference. Body area to be suctioned. Amount of expected aspirate, and history of previous liposuction. Common modalities include suction-assisted liposuction, SAL. Ultrasound-assisted liposuction, UAL. Vaser-assisted liposuction, VAL. Power-assisted liposuction, PAL. Laser-assisted liposuction, LAL. Water jet-assisted liposuction, WAL. Radiofrequency-assisted liposuction, RFAL. Air sculpt, next-generation body contouring.